Welcome to UPLEVEL, Real Health, Real Talk with Dr. Jenna Blasi. I'm Dr. Jenna. I spent years crafting ways to help women thrive, and I want to help you do the same. On this podcast, we dive deep into health at every level, focusing on the mind, the body, and the spirit. This is where real conversations meet transformational wellness. We'll be talking about all the things that truly matter, from nutrition and fitness to lifestyle, mindset, and personal development. Plus, the real deal on managing stress and navigating menopause. So if you're ready to elevate your health journey with authentic, transformative insights, you're in the right place. Let's get started. Hello and welcome back to UPLEVEL. Today we are going to talk about hormone therapy. It is time we demystified this topic. Let's talk about what do you need to know with hormone therapy and menopause. I want to cut through the confusion, the noise around menopausal hormone therapy, also referred to as MHT, previously known as HRT. Some people would say BHRT, meaning bioidentical hormone replacement. So we're going to talk about what it is, who it's for, and how to approach it with confidence and clarity, how to know what to ask your practitioners about. So whether you are approaching menopause in the thick of it or supporting someone who is, this is an episode meant to make you informed and know that you can make empowered decisions. So menopause is 1 year without our periods, and it's a natural decline in reproductive hormones. The average age is 51 years. Symptoms often start 45 and above. If you are between 40 and 44, you're in quote unquote early menopause, and under 40 is technically premature ovarian insufficiency. But perimenopausal symptoms can start in our 30s. Our symptoms are changing. And so hormone therapy is a wonderful way to support the body, but there is so much misinformation about it. There is so much fear from the big Women's Health Initiative study years ago that, it's going to cause cancer and cardiovascular disease, etc. So I really want to delve into that more deeply. What is MHT? MHT is low-dose estrogen therapy with or without progesterone to relieve menopausal symptoms. Now, if you do not have a uterus, if you've had a hysterectomy, you can use estrogen alone. If you have a uterus, you have to have progesterone because unopposed estrogen with a uterus will cause the lining to increase and can increase our risk of endometrial cancer. So when I refer to unopposed estrogen, that is only for people without a uterus, and you would be on progesterone as well if you still have a uterus. This is different from birth control. MHT uses about a quarter the dose of what we're using in birth control, which is kind of fascinating to me that women are very easily put on birth control pills at different points in their life, painful periods, this and that. Oh, here, we're going to put you on the pill that's going to manage your symptoms. But so much fear and hesitation around menopausal hormone therapy. And really, these young women being put on the pill, in my opinion, should be, there's so many other ways to address the reasons, like aside from birth control, the reasons that younger women are put on the pill is not addressing the underlying imbalances that lead them to their painful periods, etc. And so that's a time for more caution, I would say, and looking at lifestyle, whereas in menopause, our hormones are declining and adding them back in can offer great support and quality of life shifts. Pre-MHT, what are the labs and evaluations that are recommended? I want to stress that shared decision making is key. These decisions are nuanced, they can be complex, and they are not to be made in a vacuum. And so I can impart, when I'm working with patients, my expertise, my knowledge, but it's also patient preference. It's also patient lifestyle and their history. And so there's a lot of things that go into it. The hormone testing, if you're in perimenopause, there is no test that will confirm that you're in perimenopause because the hormones are all over the place. FSH, follicle stimulating hormone, which is frequently tested, can vary widely. So it could be normal one day and then high, showing you're in menopause another day. Estrogen, same thing, up, down, up, down. It's a bit like a roller coaster in perimenopause, which is also why many women feel crazy. One day you feel fine, the next minute you feel full of rage or irritable, snappy. You're not crazy, you're not alone, but the hormones are going up and down. So there's no real definitive test. So if you think you're in perimenopause and your doctor says, no, you're not, your labs are normal, it's just not true. I mean, yes, the labs might be normal that day, but that doesn't mean you're not in perimenopause. It is very important to test thyroid function, because I'm actually going to do a podcast on thyroid here in the next few weeks. Thyroid testing is essential because thyroid issues can mimic menopause. When I go through the list of thyroid symptoms, they are very like, I can't release weight, I'm sluggish, I have brain fog, I'm having trouble sleeping. There are so many symptoms with thyroid disorders that mimic menopause. Now, you can have both at the same time, certainly, but it's really important, especially if a woman is younger and is in premature ovarian insufficiency, right? Under 40, it could be a thyroid issue rather than menopause. And so doing thyroid labs, and when I talk about thyroid in my upcoming podcast, I'm going to talk about the full panel of thyroid hormones to run. I also recommend, when we're looking at initiating MHT, doing baseline labs. What is the lipid panel? What is the cardiovascular risk picture through labs and through family history? Looking at liver enzymes, blood pressure, BMI for context. Now, there's some controversy around BMI, and of course it varies, but having some baseline labs and baseline assessment is important, as well as, one of the things that MHT can do is increase breast density. So having a baseline mammogram so that you can make sure there's no cancer, for example, and you can combine ultrasound with that, because in fibrocystic breast, the mammogram doesn't read it as well. But when we talk about the risk of hormone therapy and cancer, it doesn't cause it, but it can increase breast density, which can make it harder to find, and it can feed growth. So having that baseline clearance that there's no breast cancer active in the body is important. The science shows so many benefits for MHT. Vasomotor symptom relief, number one. It is the top therapy for hot flashes and night sweats. There are herbs that can help. When we take women through our comprehensive wellness programs and we work on the gut and we gently detoxify the system, and then we dial in the nutrition and these other pieces, a lot of women, their hot flashes go away. There are some herbs. Some women get great success with them, others don't. Vasomotor symptom relief or hot flashes and night sweats, hormone therapy absolutely is excellent for this. It also can help with improved sleep, mood, joint pain, libido, energy, all of the things that the women are suffering from in this transition. Bone health, estrogen, these hormones so reduce the risk of osteoporosis and fractures, which obviously, as our estrogen decreases, our risk for osteopenia, osteoporosis increases. So being on hormone therapy will decrease this risk. Now, it's not approved for treatment of osteoporosis, but it is approved for prevention. Cardiovascular support. This is a big topic. I just did a podcast last week on cardiovascular support or cardiovascular disease in women. Timing matters. This is in relationship to hormone therapy. I think this is one of the most nuanced topics and points of confusion. And let's clarify. Timing matters. What we know now is that it seems that the greatest benefits, both for cognition and specifically for cardiovascular, are if hormone therapy is initiated within 10 years of menopause and under the age of 60. So if a woman has a hysterectomy, complete hysterectomy, let's say in her 40s, well, she should be put standard of care. She should be put on hormone therapy unless there's an overt contraindication. But then that's menopause right away, right? If she has surgically induced, so whether it's natural or surgically induced menopause, we want to be within 10 years of that for the greatest benefit. So if we're over 60 and we're outside of that 10-year window, that doesn't mean you can't take hormone therapy. I have women that I've started or continued on hormone therapy at older ages, over 60, definitely continued. We're going to talk about that shortly. But it's, again, that shared decision making, it's personal risk assessment, it's personal preference, it's quality of life. There are so many pieces that go into it. But the risks do increase outside of that window. So if a woman is over 60 and she's over 10 years past menopause, the risk benefit ratio looks different than a woman that is within a few years of menopause or within 10 and under 60. And sometimes not both of those boxes are checked, right? What if a woman went through menopause when she was 56? Remember, menopause is 1 year without your period. So menopause is a day, and then we're postmenopausal after that. And there's different, there's early postmenopause and later postmenopause. But let's say she goes through menopause at 56. And now she's 61. Well, she's still within 10 years of menopause, but she's over 60. So these aren't hard and fast rules, but these are guidelines. And this is what the literature shows us when we really go deeper into it, is there does seem to be increased risk. It is absolutely not a flat out contraindication for not starting it because, oh gosh, for so many reasons. But what I would say is, let's say a woman's not sleeping. Let's say she has terrible night sweats and can't sleep. That's not good for your cardiovascular health either, right? Let's say her mood is all over the place and she's depressed and anxious and not sleeping. That's not healthy for our long-term cardiovascular health. So there are more pieces to take into consideration. But in general, if I'm working with a woman that's, say, greater than 10 years postmenopause and over 60, and it looks like, let's say, her thyroid is having underfunctioning, I'm going to address her thyroid before I put her on hormone therapy. We're going to address the overall aspects of her health and then see what's left. And then if she's really not improved greatly, we can have that shared decision-making conversation. We become more insulin resistant in menopause, so hormone therapy has been shown to protect against diabetes. The WHI study, that Women's Health Initiative, showed, I think it was a 14 to 19% reduction in type 2 diabetes. Various studies show that no harm, there's no adverse effects when it started in that window, when it started early. The studies on cognition are a little bit all over the place, but it seems to be the most beneficial when started early, close around menopause. And that one, the earlier the better. It seems mixed on that there could be some detriment when started later. But again, these are where the nuanced conversations come in, the personal preferences and what you're struggling with. So let's talk about cancer. Cancer and clots. Those are the big fears. I hear a lot of women and they say, oh, I can't take hormone therapy because I have a clotting disorder, or I can't take hormone therapy because I have a history of clots, or another one I hear commonly, I can't take hormone therapy because my sister has breast cancer. Okay, family history is not a contraindication. That's important to know. Family history is not a contraindication to taking hormone therapy. Now, clots, sometimes we'll just say, yeah, if you have a clotting disorder, but that's not even true. And so let's break down cancer, so to speak, and clots. Let's start with cancer, because that's a big one. There is a small increased risk with combined therapy over the long term. This risk translates to roughly increased risk in 1 out of 1,000 women, but also found no increased risk of death from breast cancer. So that's interesting. So an increased risk of breast cancer in 1 in 1,000 women, but no increased risk of death from breast cancer. So these are nuanced conversations. The Women's Health Initiative studies found no increase in breast cancer risk for women using systemic estrogen only HRT. And then for both unopposed and combined MHT, right? So unopposed estrogen, just estrogen, and combined MHT, which is estrogen and progesterone, the absolute excess risk. This is a quote from a study. The absolute excess risk in past users is small and less than that associated with being overweight or drinking 2 or more units of alcohol per day. So we have all this concern over hormone therapy, and it's actually a small risk, and it's less than that with being overweight or drinking 2 or more alcohol units per day. And that was from Brown 2015 and Chabowski 2020. The other thing is some of this is offset. We've seen lower incidences of colorectal cancer and cardiovascular deaths from women who've taken hormone therapy. I love this quote from the British Medical Society in 2023, because after looking at these studies that I just quoted you, they said this illustrates how inappropriate it is to discuss HRT association with breast cancer without any consideration that a risk factor for one health condition may protect against another. We are not making decisions in a vacuum, right? It's inappropriate to discuss HRT and breast cancer without also looking at, hey, do you have a family history of colorectal cancer? Because your colon cancer risk will likely go down. And if it's in that window, your cardiovascular event risk goes down. So these are important considerations. And I can't share my screen that I'm aware of, and most of you are just listening to this podcast, but I want to pull up an infographic I have and read from it. It was in a presentation that I did for my colleagues on hormone therapy and breast cancer risk. So this was from, this is the Understanding the Risk of HRT from Newson Health. So Louise Newson has done a lot with menopause. And so she has these great infographics. So for example, breast cancer. In women aged 50 to 59, per 1,000 women over 5 years, there's 23 cases of breast cancer. Okay, so this is in, I think this was in the UK. So 23 cases of breast cancer over 5 years in the age group of women 50 to 59 out of 1,000 women, 23 cases. Now, when we look at women who use combined HRT using oral estrogen and synthetic progesterone. So I always put women on bioidentical micronized progesterone, but this was looking at women taking oral estrogen and a synthetic progesterone, increased 4 cases over the 1,000, okay? Over 5 years, 4 extra cases. In women using oral estrogen alone, and then estrogen, I feel like, is the one we tend to be afraid of. 4 fewer cases. 4 fewer cases over those 5 years. And now this is just observational study, and we only have it for 5 years. To be clear, women using estrogen with bioidentical or body identical progesterone over 5 years, or I should say up to 5 years, no additional cases. So 23 in the general population. If you're on estrogen and synthetic progesterone or progestogen, 4 increased cases. If you're on estrogen alone and even synthetic, 4 fewer cases of breast cancer. And if you're on estrogen with bioidentical or micronized progesterone for up to 5 years, they found no increased cases. Now, what's also fascinating to me is, again, that risk, that comparative risk. Okay. So, going back to the UK, 23 cases of breast cancer per 1,000 women over 5 years. I just went through the, if you're on the different types. Women who drink 2 or more units of alcohol per day, 5 extra cases of breast cancer. 5 extra. So more than combined estrogen and synthetic progesterone. 3 additional cases in women who smoke. And women who were obese or a BMI equal or greater than 30, 24 extra cases of breast cancer. And yet we make such a stink about hormone therapy. 7 fewer cases, so going the other direction, 7 fewer cases in women who exercise at least 2.5 hours, moderate exercise per week. So again, you're taking care of yourself, moderate exercise, 7 fewer cases per 2.5 hours a week. So when they put this into like a pie chart and looked at breast cancers in the UK, obesity and overweight contributed to 8% of those breast cancers. Alcohol, 2 or more units, remember, contributed to 8% of breast cancers. Lack of breastfeeding, 5%. Postmenopausal hormones, 2%. 2%. Obesity, 4 times that. Alcohol, 4 times that. Lack of breastfeeding, more than 2 times that. And the remaining breast cancers made up the 77%. So it is time to reevaluate. And if we're suffering, you're not meant to suffer. I'm so tired of people that are like, they go to their practitioner is like, oh, welcome to midlife. It's going to suck. Right? No. Okay. So going to Blood clots, because that's another concern that a lot have. Blood clots are higher with oral forms. When you're looking at transdermal, so patches, cream, so the topical, MHT has a much lower risk. And many would say, they would quote studies that show there's actually like virtually no risk found with the transdermal forms. And I've worked and studied with some doctors who actually aren't even very concerned about the oral. I was talking to a woman recently who she said, oh, I have a genetic clotting disorder, so I can't take hormone therapy. I said, have you ever been on birth control pills? She's like, oh yeah. I said, did you ever have a problem? No. So again, it's a shared decision making, because we put women on the pill all the time without thinking about it. And then we're so hesitant to help women with their quality of life in this time of life. It's really a shame, and it's a disservice. There were so many women after that whole WHI scare, which it wasn't even the research, it was the way the research was interpreted and reported. A whole generation of women were ripped off their hormones and have suffered dramatically. And I am glad that it's swinging back the other way. But I do want to talk about, before the end of this episode, that it's still not a cure-all necessarily. We still need to look at smoking and drinking and exercise and these other pieces. But it absolutely can be a game changer for women. So, and actually, let me go back to the infographic on venous thromboembolism, right? Clots. So again, because Louise, this Newson Health, she's got great infographics on all of these. And so in women age 50 to 59, there's 5 cases of embolism, of clots, per 1,000 in that same age group, right? As we looked at for breast cancer, 50 to 59, over 5 years, 5 women per 1,000 are going to have a VTE. An additional 1.5 cases of women who use oral estrogen, 1.5 over 5 years per 1,000. So again, if you want to do oral because it's convenient and you're at risk of a clot, and it's 1.5 more women over 5 years per 1,000, you might say, you know what, that's a risk I'm willing to take. That's where shared decision making and your individual case should be discussed. There are an additional 7 cases, again, when you're doing combined HRT. So the oral estrogen and synthetic progesterone, over 5 years, there's an increase in 7 cases. But women, same age group, same everything, who use transdermal estrogen with or without progesterone. So with or without progesterone, no increased risk over the 5 years they found. And then she's got another infographic for women age 60 to 69 that's also fairly low. And then stroke, some people look at stroke, and they found in women age 50 to 59 who initiate, again, that timing, initiate MHT within 10 years of the menopause transition, no additional cases, which is 4 per 1,000. And then she gives the next age group. So there's really great infographics that hopefully put things in perspective. I talked about mammogram briefly. I know a lot of people are like, a lot of people that I work with, because I'm in Sedona, no, I don't believe in mammogram, radiation, it causes, look, the amount of radiation we're exposed to in mammograms are, I did this in a presentation. I don't have the stats in front of me, but it's not that different from ground radiation that we're exposed to. It was either lesser or very similar. And so most of us will get on an airplane and fly to Hawaii and go here and there. There's a lot of there's more radiation in that than you're getting from your mammogram. And the thing is the increased breast density from hormone therapy can obscure the results. It's not going to cause cancer, but can obscure the results. So those baseline and those monitoring checkpoints are important. Genetic factors. I want to touch on this briefly. Even BRCA positive, right? They're like, I've got the gene. I'm going to do a lot of women do preventative, quote unquote, preventative mastectomies. Even BRCA positive women who've had their ovaries removed may benefit. And in fact, it's the standard of care. If a woman is in premature ovarian insufficiency, MHT given up until, so let's say she's had a bilateral oophorectomy, meaning she's had both her ovaries removed because of the risks of ovarian cancer. The standard of care, even in BRCA positive, is to put those women on hormone therapy. It has not been shown to increase breast cancer risk, regardless of how many years it was used for. Okay, so So let me actually separate. So in premature ovarian insufficiency, they put women on hormone therapy up until what would be the normal age of menopause, and then you can reassess. Hasn't been shown to increase breast cancer risk regardless of how many years. And there's observational evidence. So let me go, I might have said that slightly incorrectly. There's observational evidence that suggests that hormone therapy doesn't further increase the risk of breast cancer in women who are high risk of a family history, or because of a family history of breast cancer, who've had their ovaries removed and they have the BRCA1 or 2 genetic variants positive. So again, even in family history, even with genetic higher risk, hormone therapy alone doesn't increase you're already high risk. So if we have an extra 1 case, for example, per 1,000 from hormone therapy, it's the same increased risk. You're just starting potentially with a higher risk. But observational studies tell us that even in these cases, it doesn't further increase their risk. Okay, moving on from that, hope you all feel a little bit better and a little more informed in looking at that. Vaginal estrogen and testosterone. Let's just touch on this briefly. Like, what's the deal? Vaginal estrogen is safe with everybody. You have a personal history of breast cancer. It's not systemic. It is so important because it targets dryness, chronic UTIs, pain with sex. It is low risk and very effective. If you have vaginal dryness, if you are having painful intercourse, if you are having frequent UTIs, vaginal estrogen is really the way to go. And even women that take systemic estrogen topically doesn't always address the genital urinary or GSM symptoms. And so you may sometimes still want those suppositories. And again, working with someone that helps you find what's right for you with that. But it's safe regardless of your history. It's not systemic. It hasn't been shown to increase the risk. So it really is a game changer, because vaginal atrophy, vaginal dryness, painful sex, chronic UTIs, like these are very quality of life disturbing symptoms for women. And here's a way to address it. If you are not going to take hormone therapy from, your personal preference, your personal history, or like I said, sometimes it doesn't completely resolve it with the systemic, but it's definitely something to try. And then testosterone in women, libido and arousal is really like the main indication, and women respond differently. We could probably do a whole episode just on testosterone, so I'm not going to go into that. But one of the main indications for adding testosterone therapy to your hormone therapy is libido. I have seen many women have improved libido just from not being in pain anymore and from their systemic estrogen, sometimes progesterone combination. Their libido comes back, releasing weight. The women we work with, we're working on, again, resetting their whole system. So they're releasing weight, their energy is coming up, their mood is improving. That alone helps their libido. If they go on hormones, that can further help their libido. Sometimes testosterone is still a great addition for women, and sometimes they don't need it. I think I've debunked a lot of myths, but let's do like a rapid fire of kind of what I covered. So myth, MHT is dangerous for everyone. I mean, I could say MHT is dangerous, period. MHT is dangerous for everyone. Myth, false, debunked. It's actually safe for most women. And there are several docs out there even challenging those with a personal history of breast cancer. Like when I was trained, when I did a 2-year menopause fellowship, it was like, oh my gosh, this is an overt contraindication if you have a personal history of breast cancer. But there are menopausal doctors that are even reevaluating the literature on this. And I did have a patient years ago who was on a very low dose. She had a personal history of breast cancer, but she was on a very low dose. She came to me already on that dose, and we had a conversation. We did shared decision making. I maintained that dose for her. It really dramatically improved her quality of life. So again, very individual. Work with someone who's willing to listen to you. You are a member of that decision making, right? Shared decision making, informed consent. Myth number 2: natural means safer. I don't know if I'd say this is a myth. Bioidenticals, I put it in here. Bioidenticals can be helpful. I guess I want to clarify. Natural inherently means safer, right? Like there's no risk as long as it's natural. Bioidenticals still need some guidance, right? I showed you like the observational data on women taking estrogen with micronized or bioidentical progesterone. We didn't see any increased risk in those 5 years. We don't have long-term study past 5 years. I can tell you anecdotally, what I see in my patients. But the thing is the biggest risk factor for breast cancer is our age. And as we get older, our risk for breast cancer increases. And then add smoking, if we're not smoking, if we're not exercising, if we're obese, if we're drinking, all those other things I already talked about. And so X number of women are going to get breast cancer, right? And some percentage of those will be on hormones. Was it from the hormones? Was it not from the hormones? This is where a lot of times people say, oh, we have that story. Oh, well, my friend's mom was on hormones and she got breast cancer. She might have gotten breast cancer anyway. Like, we'll never know, but the biggest risk of breast cancer is age. And you can look at those charts of how your risk for breast cancer goes up. But the bioidenticals, they are all I will prescribe, but that doesn't mean they're completely risk-free. But there are a lot of women that come to me and they're like, I only want natural. I don't want to go on hormones. And I think that is from the fear. There's a lot of bias around hormones, both from practitioners and patients, from what we think we know, from the studies, from the people that we know. And so I'm trying to just present the research and the facts here. Another big myth, and this one pains my heart. Everyone should stop by the age of 60. That is the biggest bunch of BS. I have had so many women come to me and they're like, oh, well, my doctor took me off my hormones because of my age or how long she'd been on them, or both. You've been on them too long, or you're over 60, so we're going to take you off them. And she suffers. Quality of life goes down dramatically. If you come off them and you feel great, awesome. That's great. That's fine. You don't need to stay on them, but you absolutely should not be taken off them for arbitrary reasons such as age and how long you've been on them. Many women benefit beyond age 60 if they're healthy. I have patients in their 70s plus who are on hormones and they've tried to come off them and their hot flashes come back or they just don't feel well. And so again, you're an individual, work with someone who's going to listen to you, work with a practitioner who has had extra training in menopause, because the stats on the training for menopause are very low. 30 to 50% of graduating conventional medical students and fellows have no idea how to treat menopausal women. They're not comfortable. So that's like a third to 50%. They're not trained in it. They don't know what to do. So work with someone who's skilled and work with someone who's going to listen to what's going on, and then trust them and listen to what they're telling you as well. So there are some contraindications for hormone therapy, but they're much fewer than people think. And again, there are many who were once told no, and you may now be a candidate. So seek updated advice. All right. If you have a history of breast cancer, like I mentioned, a history of stroke, a history of blood clots, liver disease, if you have high blood pressure, that can be a contraindication if it's not controlled. But work with someone, because some of these things can be addressed and then you could be a candidate. And undiagnosed vaginal bleeding, definitely you've got to rule out like endometrial cancer and figure out why you're bleeding before you would start hormone therapy. So just make an empowered decision. I hope that you feel empowered after this. Work with a provider who understands the current guidelines and who believes that you should be part of that decision making. Consider your symptoms, your age, your medical history, and your values, what your personal preferences are, what your lifestyle is. Like the patch is great for some women. Other women, they don't want to use the patch. And remember, and this is so important. I said I'd touch on it at the end. So I'm just going to briefly, MHT is just one tool. Many of your symptoms can be the tip of the iceberg. Yes, your hormones are declining in menopause, and supporting it with MHT can be a beautiful tool, but it's not a substitute for a healthy diet or moving your body or addressing the underlying inflammation that was already there before menopause, and now it's exacerbated in menopause. And so MHT can absolutely be a game changer for quality of life when used wisely, but it is just one tool. Include diet, exercise, stress management, support systems. I've done segments on how your mindset matters. Your mindset and your attitude in menopause matter a lot. And so, some women come and that I work with and they want to go on hormone therapy. And I usually encourage them, again, if they're open, let's get your system in balance. Let's clean up your diet and dial in your nutrition and help lower the inflammation, repair the gut, see how you feel, see what's left. because there's a lot of hormone quote unquote balancing. Balancing is a bit of a misnomer, but there's a lot of quote unquote hormone balancing that can go on just with these lifestyle and anti-inflammatory lifestyle tools. And then you can be like, oh my gosh, I feel amazing. You might still choose MHT for longevity, for a variety of other reasons, but you're also not just addressing the tip of the iceberg, you're addressing all of these other pieces, nutrient deficiencies, etc., that MHT is just not, it's not the magic cure-all for. And some women go on it and it is a game changer and they feel amazing, and other women, they don't quite get the life-changing results that they wanted because these other pieces have not been addressed. So every woman deserves evidence-based guidance, individualized care. Advocate for yourself. Your health journey is personal. Your choices should be too. And you're not meant to suffer. I just really want to stress this. You are not meant to suffer through menopause. And don't let anybody tell you you are. You are meant to be supported, to be seen, and empowered. And it is one of my favorite things is to go on this journey with women to take your power back and transform your life and feel amazing. Because at this time of life, like when we hit 50 or, perimenopause or going into age 50, when we're feeling the brain fog and the energy and suddenly we have belly fat and all these things, turn this around. Not just through hormone therapy, but through diet and exercise and mindset work and all these other things that I talk about in my podcast. Turn this around so these are the best years of your life. So these are the best years of your life. I feel amazing. I feel better in my 50s than I did in my 40s. I felt better in my 40s than I did in my 30s. We can feel better. Good in our bodies, strong. Take all of these things we're talking about and don't take it lying down. You're not meant to suffer. You're meant to thrive. And I thank you for spending this time with me. This is such an important topic. And all of these components matter. So use them in a holistic approach for yourself. I hope you loved this episode, found it super helpful. Share it with a friend because I can't believe when I get online, the number of women that are being dismissed by doctors who have incorrect information. Share this with a friend and please subscribe so you don't miss an episode. Leave us a rating, leave us a review. And I can't wait to see you next time. Upcoming, we're gonna delve into thyroid. We're gonna delve into sexual libido and vaginal health, and we're gonna also talk about success. I want to go back to mindset and talk about how to be successful in anything that you endeavor. So, looking forward to these upcoming episodes. Thank you so much for joining me, and I will see you next time. Thank you for joining me on this episode of UPLEVEL, Real Health, Real Talk. I hope today's conversation inspired you to take the next step in your health journey, one that nourishes not just your body, but your mind and spirit as well. Don't forget to subscribe so you never miss an episode. And if you found value in today's episode, please leave a review. Until next time, keep learning, keep growing, and keep thriving. And remember, true wellness is a journey, and you are on the right path.